The following landmarks are identified: the right costal arch and the xiphoid process. The incision is now pointed out and marked, starting 2.5 centimeters below the xiphoid process, following the border of the costal arch approximately 2 centimeters caudal to it, ending in the mid-axillary line. The skin is incised over the previous marking, and the subcutaneous tissue is also incised. Take note that in case the incision needs to be extended, this may be done across the midline, as is now pointed out. It may even be continued in the same manner on the other side of the midline, as a chevron incision. For a more detailed elaboration of this, refer to the course Abdominal Wall Incision, Chevron. Take note of the anterior layer of the rectus sheath that is now incised. When incising the anterior layer of the rectus sheath, care is taken to keep a distance of at least 2.5 centimeters from the costal arch to prevent difficulties due to tension when closing later on. The external oblique muscle is now highlighted and transected. Take note of the transected ends of the external oblique muscle. The rectus abdominis muscle, now lifted and highlighted, is transected using electrocautery. During transection of the rectus abdominis muscle, the superior epigastric vessels may be encountered. A rough approximation of the location of these vessels is now shown. If they are encountered, they should be transected and ligated to prevent post-operative hemorrhage. The peritoneum can now be identified as a smooth, thin layer, usually with preperitoneal fat present. The peritoneum is incised and the posterior layer of the rectus sheath is incised simultaneously, exposing the round ligament of the liver. Laterally, the internal oblique muscle is highlighted and transected. Now the transversus abdominis muscle is highlighted and transected together with the peritoneum. The peritoneum and the transversus abdominis muscle may be confluent and therefore transected simultaneously. Care is however taken to place a finger dorsal to these layers to prevent injury to the underlying structures. Take note of the completed Kocher's incision. Take note that the incision was extended in this patient. The abdominal wall closure is now shown for the Kocher's incision. Because the incision was extended in this patient, the abdominal wall is closed in a medial to lateral direction. If a true Kocher's incision is used, it is advised to close in a lateral to medial direction to facilitate optimal view of the lateral corner. The posterior rectus sheath is closed using a continuous absorbable suture with intervals of approximately 1 centimeter. During abdominal wall closure, the operating table may be placed back into a neutral and slightly antiflexed position, since procedures for which the Kocher incision is used are preferably performed in a flex and reflex position or with a cushion underneath the patient's back. The suture is continued in a lateral direction to close the fascia of the transversus abdominis muscle together with the internal oblique muscle. In the lateral corner, the suture is tied and cut. With a second absorbable suture, the anterior rectus sheath is closed, again in a continuous manner with approximately 1 centimeter intervals. It is continued laterally to close the fascia of the external oblique muscle. The skin is closed using a continuous intracutaneous absorbable suture. In the event of peritonitis or an increased risk of wound infection, the skin may be closed with standing non-absorbable monofilament sutures or skin staples.